conditions requiring splenectomy or leading to functional asplenia, hematologic disorders, sickle cell disease, thalassemia, autosplenectomy, hereditary spherocytosis, immune thrombocytopenia (ITP), trauma, splenic rupture or injury, cancers, splenic involvement in lymphomas or leukemia, infections, abscesses or complications of infectious mononucleosis, chronic inflammatory disorders, rheumatoid arthritis, Feltes syndrome. Functional asplenia occurs when the spleen is present but not functional, commonly seen in conditions like sickle cell disease, thalassemia, or celiac disease. Risks are similar to those of surgical asplenia. Understanding autosplenectomy and asplenic risks ensures proactive management to mitigate potential life-threatening complications. What is autosplenectomy? Autosplenectomy is the process where the spleen becomes non-functional due to progressive fibrosis, atrophy, and scarring. This typically results from chronic damage to the spleen, often due to repeated infarctions. It can lead to functional asplenia, where the spleen is present but no longer effective. Common causes of autosplenectomy: sickle cell disease, repeated vaso-occlusive crises, and splenic infarctions lead to fibrosis and atrophy. Systemic lupus erythematosus, SLE autoimmune processes may contribute to spleen dysfunction. Amyloidosis, deposition of amyloid in the spleen can cause functional impairment. Chronic infections, recurrent infections such as malaria, may cause splenic damage. Immediate, surgical, and postoperative risks. Bleeding. Due to the spleen's high vascularity, there is a significant risk of intraoperative or postoperative bleeding. Infection. Postoperative infections can occur, particularly at the surgical site or secondary to immunosuppression. Injury to adjacent organs. The stomach, pancreas, or diaphragm may inadvertently be damaged during surgery. Pancreatic fistula formation is a known complication. Thrombosis. Increased risk of venous thromboembolism, VT, including deep vein thrombosis, DVT, or pulmonary embolism. Portal vein thrombosis can also occur. Respiratory complications. Atelectasis or pneumonia due to reduced lung expansion after upper abdominal surgery. Anesthesia-related risks. Adverse reactions to anesthesia, such as hypotension or respiratory depression.
Long-term risks. Overwhelming post-splenectomy infection. Life-threatening infections caused by encapsulated bacteria such as Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitidis. Risk is highest within the first 2 to 3 years after splenectomy but persists lifelong. Thrombocytosis and hypercoagulability. Persistent elevation of platelet counts increases the risk of clot formation. Immunological impairment. Loss of splenic filtering function for clearing damaged red cells, bacteria, and immune complexes. Increased risk of sepsis and meningitis, due to diminished antibody production and reduced macrophage activity. Nursing interventions for patients with functional asplenia or post-splenectomy status to address their unique needs and risks. Nursing interventions can significantly improve the quality of life and reduce complications for patients with functional asplenia or post-splenectomy status. 1. Infection prevention. Vaccinations. Administer vaccines as per protocol, example pneumococcal, meningococcal, Haemophilus influenza type B, annual influenza vaccine. Educate on the importance of booster doses when needed. Antibiotic prophylaxis. Administer prescribed prophylactic antibiotics, example penicillin V or amoxicillin, and ensure adherence to the regimen. Hand hygiene. Reinforce proper hand washing techniques for both patient and caregivers. Infection control practices. Encourage avoiding crowded places and exposure to sick individuals. Emphasize early medical consultation for any febrile illness or signs of infection. Patient education. Infection awareness. Educate the patient and family about the risk of infections, including overwhelming post-splenectomy infection, OPSI. Teach them to recognize early signs of infection, example fever, chills, fatigue. Wound care. Provide instructions for proper wound care if post-surgery, to prevent local infections. Medical alert identification. Recommend wearing a medical alert bracelet or carrying an identification card indicating their splenic status. Travel precautions. Advise on malaria prophylaxis and preventive measures if traveling to malaria endemic regions. Blood clot prevention. Monitor for thrombosis. Assess for signs of deep vein thrombosis, DVT, or pulmonary embolism, example swelling, pain in the extremities, shortness of breath. Promote mobility. Encourage early ambulation and leg exercises post-surgery to reduce clot risk. Compression therapy. Use compression stockings as prescribed. Medication administration. Administer anticoagulants, example low molecular weight heparin, if prescribed, and monitor for bleeding risks. Routine monitoring. Vital signs monitoring. Regularly assess temperature, pulse, and respiratory rate for early signs of infection. Lab work monitoring. Monitor complete blood count, CBC, particularly for leukocytosis or thrombocytosis. Review coagulation profiles and markers of inflammation. Pain management. Assess and manage post-operative or chronic pain as needed. Dietary and lifestyle modifications. Nutritional support. Encourage a balanced diet to strengthen immune function. Hydration. Promote adequate fluid intake to prevent dehydration and support circulation. Smoking cessation. Counsel on quitting smoking, which can impair immune function and healing. Exercise. Encourage regular, moderate exercise to maintain overall health. Psychosocial support. Emotional support. Address anxiety or fear about a splenic status and risks through education and counseling. Support groups. Suggest support groups for patients with chronic conditions like sickle cell disease. Family involvement. Include family in education sessions to ensure comprehensive care. Emergency preparedness. Emergency antibiotics. Ensure the patient has access to a standby antibiotic prescription in case of sudden infection symptoms. Contact healthcare providers. Encourage the patient to maintain a relationship with their primary care provider and specialist for regular follow-ups. Emergency protocols. Educate the patient on when and how to seek emergency medical care, example high fever, severe malaise. Coordination of care. Multidisciplinary approach. Collaborate with physicians, pharmacists, and infectious disease specialists for tailored care. Follow-up scheduling. Schedule and monitor routine follow-ups for vaccinations, lab tests, and overall health assessments.